epinephrine. First point you should remember about epinephrine is that it is agonist at alpha 1, alpha 2, beta 1 and beta 2 receptors. At lower physiological doses, the beta 1 and beta 2 receptors are primarily stimulated. But at high doses, alpha 1 stimulation this leads to vasoconstriction. The first thing you need to understand is that epinephrine's effect on blood pressure and heart rate. Okay, so we know that blood pressure is systolic blood pressure and diastolic blood pressure, and there is also another term which is mean blood pressure. Now, systolic blood pressure is a function of cardiac pumping ability, and another is venous return, and diastolic blood pressure is a function of peripheral vascular resistance, and mean blood pressure is the mean of these two. Now, as you can imagine, when I give epinephrine, it activates the cardiac pumping, or it stimulates the cardiac pumping, so this will increase to a great degree. Venous return will also increase, but not as much as cardiac pumping. Okay, and peripheral vascular resistance will also increase if the alpha 1 receptors are stimulated at very high dose. Okay, so primarily the cardiac pumping is increased, and the venous return is moderately increased, and the peripheral vascular resistance is moderately increased. So the mean blood pressure also increases. Now, on heart rate, it can have a direct action. It has a direct action and a reflex action as well. Directly, due to cardiac stimulation, there will be increased heart rate, but there will be reflex bradycardia due to increased blood pressure, and a combination of these two mechanisms will actually result in an increased heart rate. Okay, so I hope you're understanding it, that due to direct cardiac stimulation the heart rate will increase, but due to reflex bradycardia, which is occurring due to increased blood pressure, the blood pressure will slightly fall as well. These two effects will occur simultaneously, and hence the heart rate will increase moderately. Okay, so if I were to draw a graph of blood pressure, suppose this was the blood pressure which is going normally, and over here we give epinephrine. So, sorry, let me draw it a little better. Yeah, suppose this was the blood pressure. Over here we give epinephrine. So it becomes like this. Now what happens is that over here the systolic blood pressure increases. The diastolic blood pressure also increases. And obviously as a result the mean blood pressure will also increase. And as you know that as you can see, these peaks are coming closer, and this is the evidence of increased heart rate. Okay, so in your practical exams you are often given a chymographic tracing of an anesthetized cat, and over there you can identify easily which drug is given if you know these tracings. Okay, now a few uses of epinephrine. One of the most important uses is that it is the drug of choice for anaphylactic shock. It is one of the most favorite question of the examiners, and they will ask you why, both in your theory and in your practical exams. There are four reasons. Number one, due to beta 2 agonistic effect, there will be bronchodilation, and this is an effect we desire. What happens in anaphylactic shock? It is a type 1 hypersensitivity reaction. You will learn about it in your patho and micro. That is, after an initial priming or sensitizing dose, there will be a shocking dose of the allergen, and this will cause cross-linking of IgE with the mast cells, and the IgE will bind to the Fc gamma R2 epsilon receptors of the mast cells, and there will be cross-linking, and there will be mast cell degranulation, and the histamine will come out. Now the histamine will cause bronchoconstriction and vasodilatation and increase vascular permeability. As a result, the blood pressure will fall, and due to bronchoconstriction the patient will struggle to breathe. So the first effect we get from giving epinephrine is bronchodilation. The second effect, due to alpha 1 stimulation, we get vasoconstriction, so we can arrest the falling blood pressure. Again, due to alpha stimulation, there will be bronchial edema. During type 1 hypersensitivity, it will get decreased if we give epinephrine. And finally, it has a direct stimulating action on the respiratory center of brain. So due to the culmination of all these factors, we give epinephrine. Now the dose and dilution. This is also very important, and you must remember this now. We give 0.5 ml of 1 in 1000 dilution of epinephrine intramuscularly. If patient is not responding, then we go for intravenous. Now why is that? Why is intravenous not the first choice for the route of administration? We have learned that intravenous drugs, there's 100% bioavailability, and then that is in emergency situations that is the preferred route for administration of drugs. But in case of epinephrine, if we give it intravenously, we might lose the patient due to cardiac arrhythmias. Yeah, because it has a very strong cardiac stimulating property, no? So that's why intravenously, if we administer it, we might lose the patient due to cardiac arrhythmia. And so the preferred route of administration is intramuscular. If we give it intravenously, then the dilution has to be reduced to 1 in 10,000. If we can also give direct intracardiac injections, then also the dilution has to be 1 in 10,000. We can also give it by subcutaneous and endotracheal route. In such cases, the dilution is 1 in 1000. With local anesthetics, if given, the dilution has to be 1 in 2 lakh. Now, why is epinephrine given with local anesthetics? To increase their duration of action and to decrease toxicity effects. This is because the locally, if epinephrine is given, then there will be vasoconstriction, and as a result the drug will be taken slowly away from the site, and hence it will be present for a very long duration of time at the site we have administered it, and so a very small amount is sufficient for our desired effect. And finally, we can give it as a local vasoconstrictor. But the dilution has to be 1 in 1 lakh. So these dilutions are very important, okay, especially the one with the local anesthetics and the one with in case of anaphylactic shock, okay. Now, so we have discussed two uses of epinephrine. One is in anaphylactic shock, and one is in case of with local anesthetics. Now, another use is that it is a drug of choice for treatment of brittle asthma. This is one of the more variants of asthma. You learn about it in pathology. Then is also used for the treatment of bradycardia in infants and children. In adults, we give atropine. But in children, due to the fact that it has a negative effect on the cognitive functions of the brain, so it is not given preferably. And other uses are, though these are rare uses, but you may be asked in your viva, that is it is given in cardiac arrest as per the ACLS 2017 guidelines. Is advanced cardiac life support guidelines. 1 milligram in epinephrine is given intravenously. We can also give it in parainfluenza virus associated ARDS. in GIT bleed, in scromboid fish poisoning, and mastocytosis. Okay, so epinephrine, routes of administration, dilution, anaphylactic shock, local anesthetics, these are very important exam questions. Next, we move on to norepinephrine. Now, norepinephrine is an agonist at alpha 1, alpha 2, and beta 1. No beta 2 agonistic effect. And at low dose, it is a more potent vasoconstrictor because obviously the absent beta 2 vasodilatation. Okay. Now, I'll again discuss the effect on the heart. Okay, so first let's discuss the blood pressure: systolic, diastolic. Due to the fact that it is a very potent vasoconstrictor, so diastolic blood pressure will markedly increase. Systolic blood pressure will also increase due to cardiac stimulation, and hence, as a combination, the mean blood pressure will increase greatly. Heart rate, direct action, it will increase, but there will be reflex bradycardia due to such increased blood pressure. And the combination of those two effects, there will be finally a moderate bradycardia. And so, again, if I draw a curve, tracing of the blood pressure, over here I give norepinephrine. Now, how does the tracing appear? Become like this. Okay, so you can see that there is increased systolic blood pressure, increased diastolic blood pressure, increased mean blood pressure. However, the peaks have gotten wider, so decreased heart rate. Amongst users, it is drug of choice for vasodilatory shock. Or you can say septic shock. It can also be given in cardiogenic shock. And the route here is intravenous. And in fact, we do not give intramuscular. Why? This is a very popular question. Why don't we give intramuscular norepinephrine? This is because due to alpha 1 stimulation, local blood supply will decrease markedly, and this may lead to muscle necrosis at the site of injection. So we do not give intramuscular norepinephrine. And finally, dopamine. Most important point about dopamine that you have to remember is that it has a dose dependent action. What do I mean by dose dependent action? When it is given at the dose of 0 to 2 microgram per kg body weight per minute, yes, it will preferentially stimulate the D1 type of dopaminergic receptors and cause diuresis, and hence it is at such doses it is used for the treatment of oliguria. At 2 to 10 microgram per kg body weight per minute, it will preferentially stimulate the beta 1 receptors and it will cause increased cardiac contraction. There is positive inotropic effect, and hence it is used for the treatment of congestive heart failure. And from these two facts, the deduction I make is that dopamine is the drug of choice for treatment of CHF with oliguria. And finally, at a dose more than 10 microgram per kg body weight per minute, it will preferentially stimulate the alpha 1 receptors, causing vasoconstriction, and hence at such dose it is used for the treatment of cardiogenic shock. So for dopamine, all these doses have to be remembered, and route is intravenous. However, 2 points you have to remember, that is extravasation of dopamine from large veins to prevent extravasation of dopamine. Let me just correct myself. Extravasation of dopamine from the veins can cause tissue necrosis. To prevent this, we administer it into the large veins. Okay, please remember this point. So dopamine dose dependent action, route, administration into the large veins, then norepinephrine, the effect on the heart, drug of choice for septic shock, route, why not intramuscular, and then finally epinephrine, a drug of choice for anaphylactic shock given with local anesthetics, then used in bradycardia for infants, route of administration, effects on the heart, and yeah, more or less I've covered all the points with regards to the endogenous catecholamines, and the next video I'll be discussing the exogenous. So yeah, thank you.